Hello, my name is Erica Farrand, and I am an assistant professor of medicine and co-director of the ILD program at the University of California, San Francisco. And it is a pleasure to join you today to talk about non-pharmacologic management of interstitial lung disease as part of this broader educational series on ILD. So it's important to recognize that interstitial lung diseases are associated with a high burden of disease and symptoms, a loss of quality of life, and shortened survival. And because of that, it really necessitates that we consider, design, and implement healthcare delivery models that are able to address the many facets of diagnostic and management issues that come up for patients with ILD. Often, when we're thinking about management in interstitial lung diseases, we really focus on pharmacologic management, and that is reflective of the progress that we have made as a community in identifying and getting approval for medications that significantly impact the disease trajectory for many interstitial lung diseases. But as we well know, pharmacologic management only does so much in the treatment of patients, and there are many issues that come up that are unaddressed or incompletely addressed by pharmacologic management alone. To help us think about that, I really appreciate this diagram that comes from a paper published by Kreuter et al. In the Lancet in 2017. And it really highlights the many facets of care that are part of a comprehensive ILD management plan. And as you can see, treatment down in the left-hand corner, or pharmacologic management, is really just one component. And to highlight some of the others, we want to think about comorbidity management, symptom relief, supplemental oxygen use, pulmonary rehab, patient education, collaborating with ILD specialty care centers, raising community awareness and engagement at the policy level that impacts the lives of patients with ILD. Of course, we want to reach a timely and confident diagnosis and need to think about what tools, including multidisciplinary conferences, we need to employ to be able to do that. Patients do not exist in a vacuum, and so thinking about the communities that care for patients, caregivers, and how we can support them. Recognizing the psychological and spiritual impact that these diseases can have, and providing support in that space. And then thinking of end-of-life care. Now, each of these components could be a talk all in and of itself. And so we don't have time to dive into each in the level of detail that they deserve. And so I've decided to highlight just a few. And we're going to focus today on patient education, pulmonary rehab, oxygen therapy, palliative care, and support groups. And I'm showing those to you here. Okay, let's start with patient education. As we approach each of these topics, I like to start with a patient quote to really emphasize the impact that it has on our individual patients. And so I'm going to start by reading two on the topic of patient education. One individual with ILD said, "I don't know what ILD is. I would have liked a more basic approach in saying this is what's going on and this is where you can learn more about it." Another patient shared, "What are the resources? What are the websites? What can you do to enhance your health? One of the things that has helped me to understand the diagnosis and its progression and its possible origins." And then that patient went on to identify some resources that were particularly helpful to them. In general, we should think about what are the goals of patient education, and it's really to advance patient knowledge and the treatment of interstitial lung diseases. And here we can extrapolate from what we have learned from many chronic illnesses, that a well-informed and actively engaged patient in a chronic illness really helps to promote a more patient-oriented management plan, adherence to interventions, and a more holistic approach to treatment. So we can think about what are the sources of patient education. And again, this comes from the study done by Morissette and colleagues that was published in Annals of ATS in 2016 and was also the source of the quotes that I just read to you. And there are many sources of patient education out there. To highlight a few, physicians, particularly those from ILD specialty care centers, can provide a wealth of information. And that's not just the clinicians that are there, but the multidisciplinary team, the nurse practitioners, the respiratory therapists, social workers, all can provide complementary components of information for patients. Support groups. Patients are an amazing source of information for each other in learning how to navigate the many ways that an ILD diagnosis impacts life. And then finally, the internet, right? We know that this is a big source of information for many people. And so we really want to provide reliable and accurate information, point individuals to specific websites or resources where we know that information is vetted and patient-oriented. The Pulmonary Fibrosis Foundation is an excellent source of information. Many pulmonary fibrosis care center networks or other institutions across the country also have really cultivated and invested in developing educational local educational websites that point to institutional level supports available to local patients. And so patient education can happen at an individual level. It can also happen at the group level within the context of a broader program like pulmonary rehab. And the benefits there is that there are opportunities for group discussion. There can be a trained educator to facilitate. The content is tailored for ILD patients. And there's also psychological support from being in a group setting. Moving on to pulmonary rehab. Pulmonary rehabilitation is another important component of non-pharmacologic management, and it has been shown to improve exercise tolerance, improve endurance as measured by the 6-minute walk distance, and improve quality of life. These benefits are comparable to those that are seen in patients with COPD, so this is really an effective tool. When we look at the 6-minute walk distance, these results come from a study done by Dowman et al., which looked at the impact of pulmonary rehab programs on 6-minute walk distance, both in the short term and the long term. And what we can see is that in the short term, there's an improvement in the distance, in physical activity, and also in self-reported physical activity by questionnaire. When we think about more long-term impacts, this question was asked by Ryerson et al. And the results are shown here, in which there was long-term improvement seen in 6-minute walk distance, meaning not just post completion of a pulmonary rehab program, but also at 6-month follow-up. In both the 6-minute walk distance, overall physical activity, and quality of life. And this is important to emphasize, is that there's not just sort of the physical improvement, but patients are reporting an improved health-related quality of life, decreased symptoms of depression at 6 months, and there was a trend towards improvement in dyspnea, although that was not significant. More recently, there was a study that was published in Thorax this year that evaluated survival following pulmonary rehab in patients with fibrotic ILD. And in this study, they randomized 701 participants from 12 different sites across 5 countries to either an inpatient or an outpatient pulmonary rehab program, and showed that patients who improved their physical performance during pulmonary rehab had better survival compared to those who did not. Now, this finding is likely in part reflective of significant differences in the overall health and wellness of participants who are able to engage in a pulmonary rehab program, but it does suggest that multimodal approaches to ILD management may have additive benefits. It's also important to consider the impact that COVID-19 pandemic has had on pulmonary rehab programs, right? In response to the limitations to accessing pulmonary rehab programs in person during the pandemic, there is now a greater offering of online and virtual programs, which hopefully increases the accessibility of this intervention. Overall, pulmonary rehab serves multiple functions in the management of ILD, and I just really want to emphasize some of them right now. One is it provides a benchmark to help us assess disease progression. Right? Patient activity and exercise over time is an important marker of disease progression, and pulmonary rehab programs can help us to do that. It provides critical support to help patients feel like it's safe to exercise. Our patients often feel short of breath at baseline, and those symptoms are exacerbated during exercise. So many patients feel fearful about engaging in exercise safely and how much they can do and for how long. Pulmonary rehab programs provide the education, the monitoring, and the guardrails to be able to exercise safely and progress in an exercise program. Pulmonary rehab can provide a source of community for patients. It can facilitate connections amongst patients with ILD and also with this broader community of patients with chronic respiratory illnesses. And then finally, it provides patients with a sense of agency. We are often dropping a heavy burden in a patient's lap, giving them a diagnosis possibly of a progressive disease that's life-limiting, even with pharmacologic therapy, and that can create a sense of hopelessness and helplessness. And pulmonary rehab really provides an avenue for patients to actively engage in their treatment and have a meaningful impact on the trajectory of their functionality and their overall quality of life. Moving on to oxygen therapy. And again, taking a moment to reflect on the why from a patient's perspective. This from a patient with interstitial lung disease. The one thing I've always struggled with is oxygen use and things of that sort, and what are the goals. There's a lot of uncertainty amongst both patients and providers about how and when oxygen should be used. Supplemental oxygen is likely to improve symptoms and quality of life with patients with both resting or exercise-induced hypoxemia, and it's frequently used to treat hypoxemia and halt progression of ILD-associated comorbidities like pulmonary hypertension. But there's a lot of variability and uncertainty, and that's in part because there's limited evidence. Studying the benefits of O2 therapy in ILD are really challenged by ethical considerations of prospectively studying randomized patients to supplemental O2 or not. To help get around this, there was a Delphi survey of healthcare providers on the use of supplemental O2 in fibrotic ILDs to help establish some clinical consensus. And it showed that there is strong recommendation for the use of supplemental oxygen for severe resting hypoxemia. That's a PaO2 less than 55 or an SpO2 less than 89%. Or a PaO2 less than 60 with evidence of right heart dysfunction or polycythemia. There's less consensus, but still conditional recommendation for the use of supplemental oxygen in severe exertional hypoxemia, meaning an O2 dropping below 85 to 89%. And that is with or without patient symptoms. But there are also many health system level barriers to accessing oxygen that need to be addressed. Coverage, testing requirements, etc., many of which are at least in part due to the limited evidence to support ambulatory O2 use, specifically in ILD. Much of what we know, we are extrapolating from the COPD literature. There is a randomized controlled trial out of Australia and Sweden, which is comparing the efficacy of supplemental O2 use through portable concentrators on physical activity, functional capacity, health-related quality of life, and symptoms, and that will hopefully help to answer many of these questions and provide a more standardized approach to getting patients access to oxygen therapy. In the meantime, there's significant variation in clinical practice in when and how to use supplemental O2, and the issue is further complicated by delivery modes. So using supplemental oxygen is a big life adjustment for patients. For many people, it is the first physical indicator of a chronic illness, and it really is a big barrier, both physically and psychologically, to overcome. The devices themselves can actually interfere with the very outcomes that we are aiming to improve, those being activity and endurance and quality of life. So here I'm pointing towards a study that was done by Ramadurai and colleagues and published in Respiratory Medicine in 2018, which really wanted to address this question about devices, oxygen delivery devices, being constraining or cumbersome, and do they impact activity levels and exercise for ILD patients using them. And so in this prospective study of 30 clinically stable patients with ILD, investigators compared the 6-minute walk distance for patients completing it both with portable oxygen and stationary oxygen. And they found that portable O2 use was associated with a decreased 6-minute walk test distance and an increased symptom burden in the form of dyspnea and perceived exertion. So just like sort of the effort of pulling oxygen along. And this really speaks to the need for increased innovation in our O2 delivery models, as well as upfront education for patients that addresses both the benefits and the realistic challenges of using supplemental O2. Overall, the generally accepted clinical goals for patients are to maintain an O2 saturation of greater than 90% at all times, at both rest and with exertion. And this is an area that really requires an investment in education for patients because of the delays in diagnosis and the insidious onset of symptoms, many patients have been experiencing hypoxemia long before they were diagnosed. And so symptoms are often an unreliable indicator of hypoxemia. I mean, it's not infrequent that a patient will share with me that when I walk up the stairs, my oxygen will, drop into the 70s, but I feel okay, and I sit down until the level comes back up. We really need to make patients aware that even those transient drops in oxygen can be really detrimental. And so patients need to be able to monitor their O2 levels at home and understand how to adjust supplemental oxygen to accommodate changes in activity. Pulse oximeters are a key tool to enable patients to do this, although they're not without their own challenges, as studies have demonstrated that dark skin pigmentation decreases the accuracy of pulse oximeters, particularly at lower saturations, so in the settings of more severe disease. So again, this is an area where there is work to be done to improve the equipment and monitoring devices to allow patients to be safely at home and living with these diseases. Moving on to palliative care, and again, taking a moment to reflect on the why from a patient's perspective. One patient shared, "In the back of my mind, forever since my diagnosis, was how does one die from this disease? Nobody ever explained to me how you die. I mean, what's the reality of it? Does it hurt? Does it not hurt? Is it like drowning? All that stuff. Is there anything that can be done to alleviate the suffering in the process? I think that has to be explained." Another patient shared, especially how to cope on a day-to-day basis, because you basically, with this progressive disease, you're basically constantly making adjustments for your lack of function. I guess you could use the word coping. You use the word compromising or accommodating yourself. What are some of the tricks in doing that to alleviate the frustration and to be able to function as well as you can for as long as you can? So when we're thinking about palliative care, who would benefit? Right, and I think this again comes from recommendations from the article by Kreuter et al., where that initial figure was from. And we can think about palliative care benefiting patients who are symptomatic with ILD, including psychological distress. So patients who have high symptom burdens of cough or shortness of breath, who have depression or anxiety related to their diagnosis, who have questions about end-of-life care or coping. And we also want to think about referring patients who have a progressive irreversible disease where end-of-life decision-making is an important part of their disease planning and discussion. When should we refer patients? Well, this is also going to be very patient specific, but some things to keep in mind is that the disease courses of many interstitial lung diseases are variable. And so because of that, because we can't predict what is going to happen for most patients in the next 3 or 6 or 12 months, an early referral is going to serve many patients well. We really want a patient-centered approach to referrals. So again, this is shared decision-making about what are the values and goals and priorities for an individual and whether palliative care can really help to support some of those things. And then we can consider using screening tools. Again, there is not consensus about how and when they should be used, but they may be able to help us identify patients who are most likely to benefit from palliative care interventions. This figure helps to outline one way of thinking about how to integrate palliative care into an overall ILD care delivery model and emphasizes starting by thinking about what is the underlying disease or disease phenotype. Is it a patient who has a progressive disease like idiopathic pulmonary fibrosis versus a disease that may progress or stabilize, and so maybe the patient giving a little bit more time to understand the overall disease trajectory may make sense before making a referral. Compare versus another type of disease which is overtly stable, or you expect a better clinical outcome like sarcoidosis. It then helps to think about what is the balance of immediate and long-term needs that a palliative care visit may be able to address. And that includes, what's the current symptom burden? Is there unresolved psychological distress? Is there a loss of quality of life? Are these things present? Are they anticipated? What are the current support mechanisms in place that a patient has to think about these things, and what decisions have they already made in terms of advanced care planning? And that combination of what the overall anticipated disease course may be, roughly, and the balance of short-term, immediate, and long-term needs can help providers and patients make a decision on if and when to engage with palliative care. And then finally, what are the goals here of palliative care? Where overall, we've really touched on most of these, but it's to talk about symptom management, to address ways in which we can improve quality of life, to come up with an approach for managing end-stage disease, and providing clarity around the end of life and dying and what the goals are for that individual patients, and how do we make sure our management plan is in line with and honors those goals. And then also, I can't emphasize this enough, it really provides caregiver support because there is, as we know, a lot of burnout and stress and anxiety, psychological stress that caregivers experience. And so palliative care can really provide a space and a voice for those concerns. And then finally, I want to talk about support groups. We have talked a lot about the roles that clinicians can play in delivering non-pharmacologic management to patients, and have highlighted many of the people who are involved in that. That includes our physicians, our nurse practitioners, social workers, respiratory therapists, and then close collaboration between primary care and community pulmonologists, specialists in our ILD care centers, and close collaboration across disciplines with our cardiologists and our palliative care colleagues and our transplant colleagues, and rheumatologists, just to mention a few. But patients are a rich source of support for each other. They provide an opportunity to share experiences and information and resources about how to live and live well with this this disease. It's a way to provide encouragement and inspiration to help individuals to cultivate coping skills and reduces the feeling of isolation, anxiety, and depression. And again, I want to highlight the incredible work here that the Pulmonary Fibrosis Foundation has done in establishing both local and regional support groups, and also making it possible for those support groups to be accessed both in person and online. Again, hopefully improving accessibility and availability to a broader ILD population. So in summary, when we're thinking about non-pharmacologic management of ILD, we want to provide patients with information regarding the diagnosis and management, really focusing on patient education. We want to enroll patients in pulmonary rehab to improve their activity, their endurance, and health-related quality of life. We want to evaluate patients for supplemental oxygen and then make sure they have the equipment and the understanding needed to really use supplemental oxygen effectively. We want to refer patients to palliative care for patient-centered symptom management. And then lastly, we want to connect patients to support group for additional resources. Thank you for joining me in this discussion of non-pharmacologic management in ILD. By no means was this meant to be exhaustive, but I hope that it provides an overview of the many important components of management that fall outside of our therapeutic interventions. I thank you for your time and attention and hope that collectively this has answered questions that you may have.